Okay, since the time is now 12 p.m. Central Standard Time, we'll go ahead and get started as we have a lot to cover. This Lunch and Learn, welcome to our first one for 2019. This is Sick of Sepsis, and I know that this is everyone's favorite subject to code because there's so many codes you have to add when you're coding this, so I knew this would be a good subject to cover. And we'll go ahead and get started. So let's begin with some of the most recent guidance that has come out, and I know the first one says from 2012, but it is still recognized as accurate and has been reiterated here lately. So I want to go ahead and say that guidance from the Coding Clinic, second quarter of 2012 states, the term sepsis syndrome is poorly defined. You must query the MD to determine the specific condition or conditions that the patient actually has. So what does this mean? Well, this means that if your physician has documented sepsis syndrome and you have absolutely no other information as to what kind of infection you're dealing with, what kind of organism, or what actually the patient is experiencing, and all you have is sepsis syndrome, then there's nothing to code because there is no default code for that. There's no ICD-10 code for sepsis syndrome, so there's nothing you can code. So if that's what you have, you're going to have to query for more information. Resolving sepsis, per the Coding Clinic, first quarter of 2018, is not considered actively septic, so only code the underlying infection that triggered the sepsis. So what does this mean? This means that if the physician has documented resolving sepsis or the patient's sepsis is resolving, then you will only be coding the localized infection that caused the sepsis, because if it's resolving, then we're not dealing with an acute actively septic patient anymore. Now, per coding guidelines fiscal year of 2019, the term urosepsis is a nonspecific term, and it is not synonymous with sepsis from a urinary tract infection. And there is no default code for urosepsis. So what does this mean? This means if you have the term urosepsis, you cannot just assume, well, the patient has a urinary tract infection that's causing them to be septic, or the patient is septic from UTI or whatever. You cannot do that. You're going to have to query the physician for clarification, and if you can't get anything, then there is nothing that you can code. And I want to add to this, coding guidelines specifically mentioned urosepsis, but here lately I've seen several cases where the physicians are documenting something crazy like brain sepsis or abdominal sepsis. That is the same thing as them saying urosepsis. That is a nonspecific term, and it doesn't tell us what's going on with the patient. We don't know what kind of infection they've got. We don't know what all systems it's affecting. So if you see urosepsis, abdominal sepsis, or brain sepsis, and that's all you have, you do not have enough to code the patient, and you're going to have to query. So Chapter 1 guidelines, the main one that I want to point out specifically, and this has been a change from what we've been used to, there is not an automatic link anymore to organ failure or acute organ dysfunctions to sepsis, even though that's what severe sepsis is. And a lot of you like to say, well, that's the definition. The definition of severe sepsis is sepsis with organ dysfunction. However, the physician is going to have to link that organ dysfunction with the sepsis for us to code it that way as severe sepsis. Now, some of the organ dysfunctions that are routinely associated with sepsis are acute renal failure, acute respiratory failure, critical illness myopathy, and basically that's an overall body system failure, critical illness polyneuropathy, and that's basically a failure of the neurovascular system, disseminated intravascular coagulopathy, and that's sort of a blood system failure, or you'll see it written as DIC, encephalopathy, and that is brain failure basically, hepatic failure, which is liver failure, or septic shock, which is considered circulatory failure. So now when it comes to making assumptions with sepsis coding, Do not assume that sepsis is still active just because the patient is on oral antibiotics. Also, do not assume sepsis is resolved because the patient is not on oral antibiotics. If you are not certain, you need to query. And if you don't get a response, then you're only going to be coding what you have. And you do not base that on whether the patient's on antibiotics or not. Do not assume positive blood cultures indicate active sepsis or that negative blood cultures indicate no sepsis. We're going to code what the physician says. And do not assume that SIRS, which is systemic inflammatory response syndrome, do not assume that that equals sepsis. We're going to code to what the MD diagnoses the patient is having. So if he diagnoses sepsis, we're going to code that. If he diagnoses SIRS, we're going to code that. And there is not a code for SIRS related to an infectious organism. Those are all coded to a non-infectious process, which we're going to get into for a minute. But if you're dealing with SIRS of an infectious origin, then you are going to be coding sepsis, and the physician will have to document that. So definitions. A local infection that only involves a specific part of the body and the symptoms are limited to that specific part, such as cellulitis, pneumonia, or urinary tract infection. So those are your localized infections, and when you see those terms, those are the things that you're dealing with, is that specific infection to that specific body part. Now this can lead to bacteremia, which is bacteria in the bloodstream, but that's it. There's no overall body response yet. So just because there's bacteria in the bloodstream does not automatically mean that this patient is septic. It just means they're on their way there because now there's bacteria in their bloodstream. So do not assume this. It can lead to SIRS, which is a systemic inflammatory response syndrome as a response to, and this can be burns, other traumatic injuries, acute MIs, a drug overdose, or maybe an infection that has affected the whole body. If it is a systemic inflammatory response syndrome related to an infection, then we are dealing with sepsis. You may see this interchangeably with septicemia. This is an overall body response to an infection that causes an inflammatory reaction affecting multiple systems. So this is basically when the patient has a localized infection or some sort of infection somewhere in the body, and now it's making their entire body sick. Now, severe sepsis is sepsis that gets so bad that it affects organ function and causes abnormalities in one or more of those systems, such as respiratory failure, kidney failure, and encephalopathy, or encephalopathy. And those are just some examples. And I just put brain failure for that, for those of you who are not familiar with encephalopathy. And severe sepsis can then lead to septic shock, which basically means the patient is now so sick that circulatory failure is happening, and that is causing a dangerous drop in blood pressure, causing hypotension. This can be lethal and is considered a medical emergency, so this is typically not used on an active home health claim. Most of the time you will see documentation from the physician that says the shock has resolved or the patient has stabilized or the blood pressure has reached stable levels, so make sure you're looking for all of that documentation that would indicate the shock portion of the sepsis is resolved. So when we get down to coding sepsis, the biggest problem is the sequencing. So let's just start from the beginning. Official coding guidelines: for a diagnosis of sepsis, you will assign the appropriate code for the underlying systemic infection, and that is the part that messes everybody up. When y'all see underlying systemic infection, y'all think that means the localized infection. That is not what that means. When it says systemic, it's talking about what is the overall body infection. So if there's not a causal organism or the type of infection itself is not identified, Your only option here for the underlying systemic infection is A41.9, which is sepsis unspecified organism. So let's look at a couple of examples. Patient is admitted to home health for sepsis from an infected traumatic laceration to the right lower leg. There's a wound vac in place and IV antibiotics are going to be used for 6 weeks. So we're dealing with sepsis. They're coming home. We don't have any documentation that alerts us that this is resolved or it is resolving. So we don't have an organism. We don't know anything about that, but we do know we're dealing with sepsis. So the underlying systemic infection is sepsis unspecified organism, and that is an A code. Now, this is a traumatic laceration. They didn't do anything to this laceration except treatment. They're doing wound vac and IV antibiotics. They didn't say anything about suturing it closed. They didn't say anything about repairing it in any way. It's just there. So this is S81.811A, laceration without a foreign body, right lower leg, initial encounter, because wound vacs and IV antibiotics are considered active care, so we use an A. Then we're going to add the IV line care, Z45.2, and Z79.2 antibiotics long-term use. Why is this considered long-term use? Because 6 weeks of antibiotics is not a normal antibiotic cycle. A normal antibiotic cycle is 7 to 10 days, so this is long-term use. You do not see a code for a wound vac because there is no code for a wound vac, so don't go looking for one. And also the companies that supply wound vacs don't want us to add a code for a wound vac, so don't look for one. Another example, patient is admitted to home health for sepsis caused by an E. coli UTI. So the underlying systemic infection is sepsis due to E. coli, which is A41.51, and then you're going to say how this patient became septic, and it's from a UTI unspecified site. Now, we don't need to add a B code here for the E. coli because that's the only bacteria involved, and we already have identified it with our sepsis code. So adding the B code, 96.20, telling them it's E. coli is irrelevant at this point. They already know this, so don't add the code. Now, the next guideline says the coding of severe sepsis requires a minimum of 2 codes. First, a code for the underlying systemic infection, which is our sepsis code, and then followed by a code from subcategory R65.2, severe sepsis. Now, there's 2 severe sepsis codes. There's one R65.20, which is severe sepsis without septic shock, and R65.21, which is severe sepsis with septic shock. Now, you'll notice it says a minimum of 2 codes. One question that we see a lot in Ask Coding or directly to me or directly to Heather is that, well, he didn't say what organ dysfunction is available. Well, if he didn't say, ask. If you don't get it, you can't code anything. You can still code the severe sepsis because you just need a minimum of 2 codes, right? You need the sepsis code, and then you need another code to identify severe sepsis. If we don't know the acute organ dysfunction that has been linked by the physician, then we can't code it. Even though it tells us to add the code, we can't code it if we don't have it. So by all means, ask what it is. If you can't get it, you're still coding 2 codes here because it's appropriate. So let's look at an example. Patient admitted to home health with continued treatment for MRSA pneumonia, which has resulted in sepsis and related hypoxic respiratory failure. Patient will remain on oxygen continuously, breathing treatments, and PICC line care with IV antibiotics times 4 weeks. 4 weeks is not a normal antibiotic cycle. That's long. So what are we going to be coding first? It says first a code for the underlying systemic infection, which is sepsis due to MRSA. There's no other bacteria identified here. The physician has related it to the sepsis, the MRSA pneumonia, and he's also related it with the hypoxic respiratory failure. So we have number 1 code, sepsis due to MRSA, A41.02, Then our severe sepsis code without septic shock, didn't say anything about septic shock, so that's R65.20. We do happen to know what our organ dysfunction is, so we're going to add J96.91, respiratory failure unspecified with hypoxia. They didn't tell us it was acute. They didn't tell us it was chronic. It's merely unspecified. And then our localized infection, which brought all of this on, which was pneumonia due to MRSA, which is J15.212. Now, I can hear everybody saying, okay, well, you said we didn't need the extra antibiotic code. Well, we don't have an extra organism code. We don't have a B code saying MRSA. We're having to code pneumonia due to MRSA because it's a combination code, which is J15.212. So since we have a combo code, we're going to use that one rather than pneumonia unspecified. So even though we've already identified MRSA in our sepsis code, we still have a combo code of pneumonia from MRSA. So we're still going to use it. We're not just going to change to unspecified pneumonia because that's inappropriate. And then we can add, of course, our IV code, our antibiotic code, and our oxygen code. All right, so let's make our patients sicker. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore it represents a type of acute organ dysfunction. Now remember earlier I said that septic shock is typically resolved in the inpatient and not coded on an active home health claim. But let's look at our scenario. Patient is admitted to home health with continued treatment for MRSA pneumonia, which has resulted in septic shock. It is not documented as resolved, but the patient wants to go home. So the patient is coming home with PICC line care with IV antibiotics and IV fluids at a continuous low rate times 4 weeks. Okay, so basically what I'm saying here is this patient still has septic shock. It is not resolved. They still have terrible blood pressures, but they want to go home, so we're going to continue to capture it. Basically, I did that just so you can see how it's coded. So, underlying systemic infection is first, which is sepsis due to MRSA. This time, we have severe sepsis with septic shock, which is R65.21. We do not need another code for our acute organ dysfunction because septic shock is acute organ dysfunction, because it's circulatory failure. And then we're going to add our culprit, which is pneumonia due to MRSA. Again, this is a combo code, J15.212. And then we can add our IV line care, our antibiotics long-term use. And then if you're dealing with IV fluids and TPN or things like that that don't really have a specific Z79 code, you can always use Z79.899, which is other long-term med use. Okay, let's make things worse. Sepsis due to a post-procedural infection. Okay, this is a very long guideline. I was not going to type it all out, so I'm just going to summarize the important thing to know. What you need to know when dealing with post-procedural infections and sepsis is the T code is at the top, okay? So when you're dealing with sepsis in a post-procedural situation, your T code, rather than the underlying systemic infection, which is the sepsis code or the A code, you're going to have to identify the T code first. What is the actual problem now that is causing the sepsis? The T code is on top. Now, if you're dealing with an obstetric infection, this is still post-procedural, then you're dealing with an O code. And just keep in mind that the O code is over them all. So let's deal with two situations. Patient is admitted to home health for continued antibiotics times 4 weeks for a recent hospitalization due to a post-surgical infection of the subcutaneous tissue surrounding the patient's recent cholecystectomy site. The MD states that the surgical incision cultures have grown Pseudomonas, and the patient is suffering from Pseudomonas sepsis related to his surgical wound infection. Okay, so what do we know about surgical wound infections? T code. So that's going to be first. So we have T81.41XA, infection following a procedure, superficial incisional surgical site, and it says initial, but this is because of active care because we have continued antibiotics times 4 weeks. We have next another T code because now we have sepsis following a procedure. So this is T81.44XA. So you actually have 2 T codes that you have to put there. You're also going to use an A on this. Then we're going to add the underlying systemic infection code, which is sepsis due to Pseudomonas, A41.52. And then, of course, our long-term antibiotic code. I didn't say anything about them being IV antibiotics. I just said antibiotics for 4 weeks. So we have long-term use antibiotics. So let's look at it for another minute. We have a post-procedural infection sepsis. So we have to have at least 3 codes here. Our infection code for whatever the underlying infection is. Then we have our sepsis code, which is our sepsis following a procedure code. And then our systemic infection code, which is sepsis due to Pseudomonas. I can hear everybody moaning all the way from here, even though you're all muted. I hear everybody moaning. Okay, so this is a slide that I added because these are the codes that I get asked for the most because they're not in the normal spots. T is at the top and O is over them all. So what am I talking about? Okay, whenever we get a patient that's septic because of their IV line or their portacath or their Hickman or their triple lumen, everybody goes to looking for infections due to a vascular device, right? Well, guess what? That's not where you code these. They have their own special codes, and it's always hard for folks to find. Those are T80 codes. So when you have an infection because of a central line or a port or a CVAD or something like that, you are going to be looking, and especially if it's causing sepsis, this is a bloodstream infection caused from a catheter, and you're going to be using a T80.211, either an A or a D, depending on the care code. So you're probably going to want to have this handy. If it's an immunization that caused sepsis, first thing you want to do is, oh, we had a procedure, it's caused a sepsis, it's caused an infection, I need to go and find a T81 code because that's infection following a procedure. No. Immunizations are coded to T88.0XX and then A or D. So what if we've got an internal joint prosthesis infection causing sepsis? Those y'all can pretty much find. Those are the T84.5 codes. So you'll code that first. Then you're going to have your post-procedural sepsis code, which is the T81.44 code. And then you can go into your A code. What if it's a urinary catheter causing sepsis? Again, you go looking for that code, you can't find them. They have specific codes. T83.51 is where you start. Now, every one of these, because these are post-procedural, you're going to have to code one of these, and then you're going to have to add your T81.44X, A or D, which is post-procedural sepsis code. Then you will use your A code to identify the underlying systemic infection. If you're dealing with obstetrics, such as an infected C-section or an infected perineal repair, God help her, wound, and this is causing sepsis, then you're going to have to identify this with your O code first. Remember, over them all, which is an 086.00 all the way through 086.03. And you also have 086.09 to identify the levels of these infections as well, because they've branched those out too. Now, if you're using one of those, you're also going to have to add an 086.04 post-obstetrical procedure sepsis. And then you're going to use your A code for sepsis. underlying systemic infection. Clear as mud, right? Keep this slide handy, print it out, put it with all of your other stuff, maybe even as close as your comorbidity list, because these give you starting points for all those really serious infections. So what if a post-op infection isn't a T code? Awesome, right? So let's say a patient gets diagnosed with gram-negative sepsis that causes the patient to have severe septic shock with DIC and critical illness myopathy, all stemming from an infected gastrostomy. The patient will need daily wound care and IV antibiotics. Weekly lab work is also going to be done. So is this still post-procedural sepsis? Let's assume this gastrostomy has been there for 10 years. Is it still post-procedural sepsis? Yes, it is. There's no time frame that dictates to us whether this is a post-procedural sepsis or not. It is post-procedural sepsis because the patient wouldn't be septic if they didn't have an infected gastrostomy. They wouldn't have an infected gastrostomy if we hadn't stuck a gastrostomy in them. So, yes, it's still post-procedural sepsis. Is the first code in our sequence going to be a T code? Nope, because an infected gastrostomy is not a T code. Are we even going to need to use a T code in our sequence? Yep, we are. And how many codes at a minimum will we need? Well, if you look at everything that I underlined, we're going to need 7. So we have our K94.22 gastrostomy infection, T81.12XA post-procedural septic shock, and then A41.50 gram-negative sepsis. Then we have our DIC, our critical illness myopathy, our IV line care, and our long-term use antibiotics. What if the sepsis is resolved? Patient gets diagnosed with sepsis due to pneumonia. MD documents it's resolved, but they're still on antibiotics times 1 week. Well, 1 week, pretty normal cycle, so we just need J18.9 pneumonia. We're still treating that, but not the sepsis. Let's say patient gets diagnosed with post-procedural sepsis. Documentation that says that the sepsis is from Proteus mirabilis due to a right hip prosthetic hip joint infection. Patient continues on oral antibiotics times 5 days. In the discharge summary, he states the sepsis is resolved. Well, we're still getting active care for our infection with antibiotics, but it's only 5 days. So it's T84.51XA, and then our Proteus mirabilis to tell us what the infection is, but we don't need any sepsis coding because it's resolved. What if we can't get any more info? Patient is admitted to home health after suffering from sepsis related to an acute UTI and pneumonia. The UTI was caused by E. coli, and the pneumonia produced a sputum culture of Pseudomonas. The blood cultures have not returned yet, and the MD's documentation on the home health referral states patient is still suffering from the effects of sepsis. Well, we have 2 infections here. We have 2 bacteria here. Do we have enough to code it? We actually don't, because we don't know what's causing what. Query to the MD states, not certain which infection caused the sepsis, could be the pneumonia, could be the UTI, or a combination of the 2, code as is. Perfect. We will. Well, we don't know what organism's causing the sepsis, so we just have to use A41.9. And then our UTI is caused by the E. coli, and then our pneumonia due to Pseudomonas. What if the MD says, well, it's caused by both organisms? Then we're going to have sepsis due to E. coli, sepsis due to Pseudomonas, our UTI. We don't need a B code here because we've already identified E. coli and Pseudomonas. And then we have our pneumonia code due to Pseudomonas because it's a combo code. Now, viral specifics. In the time that we're in, which is flu season, and gastroenteritis, this is basically just a reference sheet for you. If you have viral sepsis, your only option to identify that sepsis is A41.89. So I've given you some examples of if it's viral sepsis, you'll use these codes. If it's sepsis due to viral syndrome, which is, believe it or not, different, there's a code specific for viral syndrome. Sepsis due to influenza A, remember this is not novel A. Don't do that. If it's influenza A, it's influenza due to other identified influenza virus, not novel A. They have to say novel A. What if it's the stomach bug? Viral intestinal infection, West Nile, you have West Nile virus, and then sepsis secondary to hepatitis C, other specified sepsis, and then your hep C. So in summary, in cases of sepsis, look for the MD to document resolution. If it is not clear whether it is resolved or not, you should query the agency for clarification from the MD. Keep in mind, the continuation of oral antibiotics alone is not a continued treatment of sepsis. MD does not have to say severe sepsis. It becomes severe when organ failure is present and associated with the sepsis. Most organ failure issues are resolved while the patient is in the acute inpatient facility, but not always. So what do? You ask. The R65.20 and the R65.21 codes may never be listed as primary codes. They are consequences of the underlying systemic infection, and those are your A codes. So keep in mind, those will never be your primary code. Alrighty, 12:31, a minute over. We're not able to open up for questioning, but I will encourage you to either email Ask Coding or email me or email Heather Dudding if you have any questions. This has been recorded. If you need to hear it again, it will be uploaded into iTrain as soon as I get that available.